Hi, everyone. Welcome back. My name is Alice Tseng. I'm an associate professor at the Faculty of Pharmacy, University of Toronto, and I'm at the Immunodeficiency Clinic, Toronto General Hospital, University Health Network, and I'm part of the CHAP executive. And we're two of our HIV101 series on managing drug-drug interactions. Today, we're going to focus on induction interactions and talk about interactions with non-oral and injectable antiretrovirals. Now, with induction interactions, they occur when an inducer binds and activates transcription factors, leading to an upregulation of messenger RNA. This increases protein production and synthesis of new drug metabolizing enzymes, which clinically results in increased drug clearance and a reduction in concentrations of the substrate drug. With the revolving door analogy, which we talked about last time, if you think back to this door, it's still continuing to revolve at a fixed speed. So within an inducer, you're not making the door spin around faster, but what's happening is there are additional doors being built. And once the new doors are functional, then people are able to leave the building more quickly. And then from a drug standpoint, you get a reduction in drug concentrations, which, in general, we don't like drug induction interactions because particularly with antiretrovirals, there's a risk of decreased efficacy if you drop the levels of antiretrovirals too low, and potentially a risk of drug resistance developing. In terms of time course of induction interactions, it's different from inhibition interactions. So with induction interactions, it's a relatively slow process where there's a maximum onset happening about 7 to 10 days after an inducer is started. So if you think about constructing a new revolving door, it just doesn't appear overnight. It takes time to plan, to order, to build, get it functional. And similarly, when you stop an inducer, it can take a couple of weeks for the inducer to be cleared and for the additional enzymes to degrade, just like it takes time to disassemble and remove additional revolving doors. This is a gentleman, 72 years old, on atazanavir ritonavir with 2 nucleosides and virally suppressed. He was switched to a single tablet regimen of darunavir, cobicistat, emtricitabine, and TAF. You could see on a number of co-medications, including warfarin. He'd been on a stable dose of warfarin of 10 milligrams daily for the past year with a recent INR of 2.5 just before the switch. However, what happened after switching from atazanavir ritonavir to darunavir cobicistat is, in fact, at a month, his INR had increased to 3.4, and he was reporting frequent nosebleeds. His warfarin dose was reduced, but his INR remained elevated, and it wasn't until we eventually reduced his warfarin dose down to 4 milligrams a day that his INR returned to the desired range. So there was a 60% reduction in his warfarin dose. And the question is, well, what happened? And I think we talked about this last time about how cobicistat and ritonavir can be similar in they both have inhibiting effects on CYP3A4 and PGP. However, they are not identical twins. They are fraternal twins, if you want to think about it that way. Ritonavir induces a number of metabolic enzymes and pathways. So it induces CYP1A2, 2B6, 2C9, 2C19, as well as UGT, whereas cobicistat does not. It has no inducing effect. So it is really important to remember this when you're switching from one booster to another. And with our patient switching from ritonavir to cobicistat, you lost that induction effect of the 2C9, and therefore the warfarin concentrations which were at a higher dose to compensate for that induction then became too high. Other antiretrovirals with enzyme-inducing properties, the older NNRTIs, efavirenz, etravirine, and nevirapine are moderate inducers of CYP3A4, and some also induce 2B6. We've already talked about ritonavir being an inducer. Elbitagavir on its own is an inducer of 2C9. With respect to co-medications, rifamycins, anticonvulsants, St. John's wort, and dexamethasone are considered potent inducers of CYP3A4 and PGP, and many are contraindicated with antiretrovirals. With respect to starting and stopping inducers, therefore, as we mentioned, the onset is delayed. It can be managed as if you're starting an inducer, you can then increase the dose of the substrate drug after a couple of weeks. After you stop the inducer, you titrate back to the original dose. And it is important to wait for that deinduction period to clear. One example, if you look at the doravirine monograph, doravirine is a CYP3A4 substrate. It's contraindicated with potent enzyme inducers. And it says, for instance, if you've got somebody on an anticonvulsant and you want to stop that anticonvulsant so that you can go on doravirine, you need to wait for at least 4 weeks between stopping that inducer before starting doravirine to make sure that there is no leftover induction still happening. Now, with drug interactions, hate to say it, but size can sometimes make a difference. Specifically, both the dose and the potency of the inducer or the inhibitor can influence the extent of an interaction effect. For example, if you're heading towards a revolving door at the same time as a small child, you're probably going to be able to get there faster or push them out of the way because you're bigger. But if an entire busload of children or a higher dose of drug, if there's more drug available, gets there before you, you're going to have to be the one to wait. Similarly, the potency of a particular inducer or an inhibitor will determine how much of an effect they'll have. So there's a big difference between one small kid in front of you versus one very large sumo wrestler. So you can guess as to which one's going to be more of a problem. This slide shows some real-life examples of how potency and dose-related effects of inhibitors and inducers play out. So if you look, first of all, on the left-hand side, you can see when the dark blue arrows, a larger dose of dolutegravir has a greater effect on increasing metformin concentration. So with dolutegravir 50 milligrams a day, there's a 79% increase in metformin due to inhibition of OCT2. If you double the dose of dolutegravir to 50 milligrams twice daily, now your metformin doses concentrations are going to be increased by 145%. And with respect to induction, in the light orange bars, you can see that ritonavir at a dose of 100 milligrams twice daily, it induces CYP2B6 and it decreases bupropion concentration by 21%. With the higher dose of ritonavir, so now going up to 600 milligrams twice daily, there's a greater reduction. Bupropion concentrations are now decreased by over 60%. Moving to the right-hand part of the slide, you can see an example of two different types of inhibitors in the light blue. So ketoconazole is a potent CYP3A4 inhibitor, increases midazolam concentrations by almost 800%, whereas fluvoxamine is considered a more weak or moderate inhibitor of CYP3A4, increases midazolam by only 66%. In the red, you can see the effects of different rifamycins. So rifabutin is generally considered to be a moderate inducer of CYP3A4. It reduces concentrations of bictegravir by 38%, whereas rifampin, a more potent inducer, reduces concentrations of bictegravir by 75%. How do you manage these sorts of situations in real life? This is a 57-year-old gentleman in our practice who had HIV for over 30 years with extensive HIV resistance, had been virally suppressed on a trio regimen of darunavir, ritonavir, etravirine, and raltegravir twice daily, as well as tenofovir and emtricitabine. He was diagnosed with prostate cancer, and after a period of time progressed on first-line therapies. And so the oncologist wanted to initiate enzalutamide. However, enzalutamide is an extremely potent inducer along the same lines as rifampin. You can see with midazolam, reduces midazolam exposures by close to 90%. Also has induction effects on other CYP isoenzymes and even UGT as well. So very broad risk of interactions with many different types of antiretroviral agents. Enzalutamide itself also has a very long half-life, so the effects on enzymes can persist for a month or more after stopping. And most resources will tell you not to use enzalutamide with antiretrovirals, but what if you can't? I mean, clearly we can't stop HIV therapy in this patient. So we decided to take an approach where we were going to modify and monitor really closely. With respect to his antiretrovirals, we thought maybe we'd have more luck with increasing the ritonavir dose from 100 to 200 milligrams twice daily to boost darunavir. We would keep etravirine as it was for now, and then we would replace raltegravir with dolutegravir. It's got a higher genetic barrier to resistance, and we also we decided to give it twice daily for the extra insurance. So a month before starting chemotherapy, we switched him from raltegravir to dolutegravir just to ensure that he would tolerate it. After starting enzalutamide, 1 week later, then we doubled the dose of ritonavir to 200 BID. And so again, keeping in mind the time frame of induction interactions, they don't happen immediately. So we gave it a week for that induction to start ramping up before doubling the dose of ritonavir, because otherwise we know it's not very well tolerated. Doing therapeutic drug monitoring of his antiretrovirals, 8 weeks after starting enzalutamide, his antiretrovirals were therapeutic. So this strategy was effective, and we were able to keep this patient virally suppressed for several years, in fact, on this regimen. So sometimes you need to be a little creative. Moving on to different routes of drug administration. So obviously there are many ways to give medications in addition to just orally. And the question is, what about the drug interaction risks with these other routes? This is a 60-year-old gentleman who was diagnosed more recently with HIV and then started on tenofovir, FTC, and boosted darunavir. And was virally suppressed, so doing well that way. He also has had asthma since the age of 4, COPD and osteoporosis, and his co-medications include a number of drugs as well as inhaled budesonide. And what he noted to us on one visit was that things are going well, but ever since starting his ARVs, he'd noticed that his skin had gotten really, really thin, much more prone to bleeding and bruising, so 90% worse since starting his ARVs. And what in fact is that's actually a very well-known dose-related side effect of corticosteroids. This study of people at an outpatient chest clinic looked at the effect of inhaled corticosteroids on skin quality, so skin thickness, as well as bruising or thinning of the skin, and they found that people who are on oral steroids and high dose inhaled steroids had significantly thinner skin at all 3 sites compared to those on lower dose inhaled corticosteroids. Another important consequence of using a booster with corticosteroids is the risk of Cushing syndrome. This slide shows results from a retrospective case control study where they looked at cases of Cushing syndrome that were recorded in the French pharmacovigilance database. There were 35 cases of Cushing's in people with HIV in this database, and in 34 out of 35 cases, they were also on either ritonavir or cobicistat. And in fact, when they looked at the type of steroid that people were taking, 80% were on inhaled fluticasone. There were also 3 people on intra-articular triamcinolone, so intra-articular injections, and only 2 were on oral budesonide. Again, this really highlights the risk of significant interactions with non-orally administered corticosteroids. There are also numerous case reports, for instance, of topical creams or even corticosteroid eye drops causing Cushing's syndrome in people on also on a boosted antiretroviral regimen. If beclomethasone is the preferred agent. It's a prodrug, which is hydrolyzed via esterase enzymes to an active metabolite, which is then metabolized by CYP3A4 and 5. This study showed that when beclomethasone was given with twice daily derivative-ritonavir, there was a bit of an increase in exposures of the active metabolite, but this was felt to be clinically insignificant, and there was no adrenal suppression noted when this combination was given for 28 days. So in the context of corticosteroids, certainly beclomethasone is the preferred option if you do need to use a steroid. Also best to minimize use. I think it's really important to ask people about what things they're taking, because they may not think immediately of things of drugs that are not pills. And if possible, to avoid interactions, you can also switch to an unboosted ART regimen if that's possible. Now, what about in long-acting injectable regimens? Are we home free with drug interactions? Well, in some cases, I'm going to say yes. So some interactions that are relevant with oral ARVs are not a problem with injectable ARVs. So specifically those that involve absorption. So acid-reducing agents and cations, these are concerns if you're giving oral rilpivirine or oral integrase inhibitors, but with injectable rilpivirine or injectable cabotegravir, not a problem. However, as with other non-oral administration, with long-acting antiretroviral therapy, you do have systemic drug concentrations, and there is a risk. They are susceptible to interactions with enzyme inducers, and they're contraindicated with both oral and long-acting treatments. This slide shows how rifampin can impact concentrations of long-acting drugs, reduction in cabotegravir of almost 50%, an 80% reduction in injectable rilpivirine, over 80% reduction in lenacapavir, so very significant. Now, while cabotegravir and rilpivirine are generally considered enzyme neutral, so they can be victims of drug interactions, but they don't tend to be perpetrators, whereas lenacapavir is not only can be a substrate or victim, but it can also act as a DDI perpetrator. It is a moderate inhibitor of CYP3A4 and of P-glycoprotein, and so the monograph does include a caution about using with narrow therapeutic index drugs. Another reminder is that because by design, lenacapavir is meant to last in the body, and so in fact, the drug interaction risk with lenacapavir can persist for up to 9 months after the last subcutaneous dose of lenacapavir. That's from the monograph. So I know half the time we can't remember what we ate yesterday for dinner, but it's really important to get a good medication history. So for instance, even if somebody was on lenacapavir and stopped it, important to find out when their last dose of the lenacapavir was to see if there still is an interaction risk. This poster was recently presented at the CORI conference, and it was more of a DDI exercise. So they looked at this prescription database in the US of over 400,000 people who received at least one prescription for an oral or injectable PrEP prescription in 2024. So this didn't include lenacapavir. And then what their exercise was, well, what if all these people were given lenacapavir instead for PrEP? What would the drug interaction risk be? When they looked at the profiles of all these people, over 80% were on at least one other co-medication, and 25% were on a co-medication that was a substrate of CYP3 or P-glycoprotein. So theoretically could have an interaction risk with lenacapavir. Drilling down at the actual drugs of concern, less than 1% of the time, according to the lenacapavir PrEP monograph, there would need to be a dose change in lenacapavir, and that's with their potent inducers, whereas 13% of the time there would be a need for monitoring or potential dose modification. And so I think that's an interesting exercise. Keep in mind that this was done in a PrEP population. If you're using lenacapavir for treatment, often it can be in somebody older with more treatment resistance. There can also be more co-medication, so that the drug interaction risk could be different. It could even be higher depending on the situation. This is a 55-year-old gentleman who's suppressed on abacavir and nevirapine since 2005. You can see quite a few number of co-medications to manage diabetes, hyperlipidemia, and bipolar disorder, and he wants to switch to injectable cabotegravir or rilpivirine. With respect to interactions, the nevirapine right now is acting as an inducer and potentially decreasing concentrations of these drugs listed here on the left: bupropion, aripiprazole, loxapine, sitagliptin, and tadalafil. So in some cases, the doses might be higher than usual to compensate for that inducing effect of nevirapine. He's also on pantoprazole, which we know is contraindicated with oral rilpivirine. So to make this switch, we did a lot of discussion with the psychiatrist about how to manage potential dose adjustments of the psychotropic agents. The decision was made to decrease the bupropion 2 weeks after stopping the nevirapine. So again, allowing time for that induction to wear off before bringing down the bupropion dose. And then it was felt with the other co-medications, it was possible just to monitor response over the first month or two and titrate as necessary. He decided to quit pantoprazole cold turkey. This was in the days when we were using the oral lead-in, so that took care of that. And he made the switch with very good effect and continues to be virally suppressed. To summarize interactions with long-acting agents, the absorption ones are not relevant. Enzyme inducers are generally a problem, regardless of the route, and lenacapavir can act as a perpetrator. And so to wrap up part two, so everything we've talked about today, we talked about induction interactions and the dynamics and how it's very different compared to inhibition interactions. With induction interactions, there's a slower onset and slower offset. We also discussed differences between ritonavir and cobicistat. So ritonavir is an enzyme inducer, cobicistat is not. So it's a really important distinction. Talked about all the different things to be aware of, that certainly drugs administered through non-oral routes, so topical, inhaled, or even injectable, there can be an interaction risk, and your strategies, same types of approaches in terms of monitoring and dose adjustments, TDM, and just keeping in mind, again, the time frame will really inform the specifics of how you handle each case. So that's it for today. Thanks for tuning in, and hope to see you soon for part 3.